sure. Can you see my screen at all?
Yes, please just start your presentation.
Okay. So I have no disclosure to make. I have a few objectives to meet, hoping to meet. We'll look at the utility and limitations of MRI in evaluating the neural foramen. We'll review the anatomy of the neural foramen and look at practical applications of this anatomy, particularly in transforaminal procedures from my end, like epidural steroid injections. So this is the focus of our talk, the anatomy in the lumbar spine, the neural foramen. So we have here the boundaries of the neural foramen being the end plates of adjacent vertebral body, the intervening disc, the superior and inferior articular process, and the pedicles of the rostral and the caudal vertebral bodies. We'll concentrate our talk on this structure. So in terms of the workhorse that we do for this imaging, we have the basic sequences. We have a sagittal T1, a sagittal T2, and a sagittal stair sequence. As you can see, the clue is mainly on the signal of fluid. CSF is bright on T2, as you can see here, and you can see the distal cord, the conus, and the neural structures. The opposite is the CSF is dark on T1, and we have another sequence that gives us an idea about the basically the fluid content or the fluids, the marrow signal in general. So you can see the steer sequence, you can see the bright signal in the disc, and you have a desiccated disc in this picture. On the axial view, you also have basic sequences, the axial T2 and axial T1. And you can see the thecal sac with the layering of these nerve roots in the dependent portion of the thecal sac. And you can see also the exiting nerves. Fat is your friend. And basically, we look at the particularly the lumbar neural foramina on sagittal or parasagittal images. And you can see here that on T1, this is the signal of your subcutaneous fat. And so the fat surrounding the neural and the vascular structures are also bright on T1. And also they're bright on T2. But let's look at T1. You can see that this is the neural foramen looks like a keyhole. You have the nerve root and you have the intraforaminal course of a radicular artery. So they are side by side, and you can see the bright signal surrounding both the structures. By the way, can you see my cursor? Sir,
yes, we
you are
can.
muted. You can see my cursor,
Yeah,
right?
we can. Yes,
okay,
sir. Yes,
thank
sir.
you. Okay, so basically, fat is your friend. And the perineural fat surrounds the nerve root and the vascular structure. And you can see the, because of the low signal of this structure, you can clearly delineate the neural foramen and the neurovascular structure. Again, you can see the perineural fat on the sagittal view. And here you can see the nerve root surrounded by perineural fat on the axial view on T1. So it's another example. You can see the nerve roots on each level surrounded nicely by the perineural fat. There are many factors that contribute to the shape and size of the neural foramen. For example, here, you can see the disc material encroaching and effacing the inferior portion of the perineural fat. And here also, you can see some encroachment into the neural foramen because of thickening of the ligamentum flavum. And it doesn't help that this patient also has a herniated disc. You can see this a background of diffuse bulge with central, subarticular, and foraminal disc herniation. And the narrow pedicle, they all contribute to narrowing of the central spinal canal plus the neural foramen, more on this left side. So again, just illustrating degenerative changes in the facet and the thickening of the ligamentum flavum, all contributing to the appearance, the overall size and shape of the neural foramen. And you can see here that this is a nice neural foramen looking like a keyhole with a nerve root in between, just below the pedicle. And other things that can contribute to the overall size of the neural foramen would be the loss of disc height, for example. So if you lose disc height, then the height or the vertical diameter of the neural foramen would also decrease, like in here. Plus you have bony spurs also encroaching into the neural foramen, and you can, on this CT, you can make out the nerve root that is a little displaced here. So again, more examples of that. Disc herniations. Here you have this extrusion and the disc material, again, encroaching into the neural foramen. And there is complete effacement of the inferior perineural fat. There is some encroachment here, but you can still see what's left of the perineural fat. And you can see also degenerative end plate changes and fatty changes in the marrow. And this would be one of the main things about MRI is you can tell, you have information about the marrow signal if you have degenerative disease. Also the height and the hydration status of the disc. And you can see low signal means it's a desiccated disc. And plus other, soft tissue structures, you can see the degenerative facet changes there. And fatty infiltration of the multifidus muscles related to degeneration, denervation or disuse atrophy, as we call it. And you can see here the disc material, again, with on the background of short pedicles, there's really narrowing of these bilateral neural foramina. And I find this useful. I've written like a book chapter many years ago, and I think, this grading of neural foramina by Lee et al. May be still useful. You can see for grade 0, you have a nice, complete delineation of the neural foramen looking like a keyhole with the nerve root and the radicular artery. And if you have effacement of the perineural fat on the vertical direction, like so, then that's a grade 1 or mild stenosis. On the horizontal direction also, you can see preservation of the fat plane or the perineural fat on the vertical direction, but there's some effacement here. That's still mild. That's grade 1. For grade 2, it's effacement of the perineural fat on both vertical and horizontal planes. That's moderate. And if you have deformity plus effacement, you cannot really, maybe you can see a trace of perineural fat. This is severe stenosis. So that's, I still find this useful. There are many gradings, but I think this is a simple way to look at the neural foramen. The main limitation of this MRI is when you have an instrumented patient like this, and you can see all this, what we call susceptibility artifacts coming from the hardware, from the screws. It basically this distorts the signal and you will lose signal. We have techniques to reduce this, we call it Mars metal artifact reduction sequence, but it's not 100%. Sometimes you can still make out the nerve roots, but how much of that is really effacement or just the abnormal, the dark signal encroaching on the neural foramen is anyone's guess. So this limits the evaluation of the neural foramen whenever you have an instrumented hardware. But other non-invasive means like CT, you can still somehow get some information. For example, here you can see the nerve root just below the pedicle. You can see the nerve roots there on the axial, and you can still see the nerve roots there also. And you can still see, it's not as good as MRI, but you can still see the dark signal of the inferior perineural fat. And on a myelogram, same thing. You can see the nerve root sleeves there, and the thecal sac with the cauda equina. You can see again the nerve root filling with contrast. So these are alternative means to look at the these structures on an instrumented patient. Although sometimes you'll have a similar artifact, but it's not as extensive as the blooming artifact, as we call it, on MRI. So again, we look at the neural foramen, the boundaries that I mentioned earlier, the pedicle of the superior vertebral body, the inferior vertebral body, pedicle, the end plates and the intervening disc, and the superior and inferior articular processes, the posterior boundaries. And we can make measurements. You can look at the height of the neural foramen and the width on the AP diameter based on this 3D reconstructed CT. Most of the studies, there will be a few studies that I'll mention. Here is the classic, this is a sagittal view. You can see the pedicle, and you have the spinal ganglion, and this is traditionally the safe triangle, as they call it. And this applies more to minimally invasive procedures like epidural steroid injection. So below the pedicle, this is what we call the subpedicular approach, and they will put the needle there and inject the concoction. And there is this study that I'd like to highlight in this that may be important for transforaminal approaches. You have the neurovascular structures starting from the intersegmental artery going distally, and you have the nerve root within the neural foramen. This basically shows the intraforaminal course of a radicular artery in relation to the exiting nerve root and the neural foramen. So again, we can do these measurements, the height of the neural foramen, the AP width of the neural foramen, and we can divide this into 4 quadrants. So you have the superior, anterior, posterior, posterior quadrant, the anterior inferior, and then the posterior inferior quadrants. And you can delineate. This is based on flat panel CT. It's kind of like similar to spinal angiography, except that it doesn't subtract. So you don't have like a DSA, but you actually have 3D images reformatted on a flat panel computed angiotomography. And you can see here the intraforaminal course of the radicular artery. You can delineate parts of the epidural venous plexus there, and they have done measurements, dimensions in relation to the anterior radiculomedullary artery, like say the vertical distance to this dividing line between these 4 quadrants, and also the horizontal distance based on this line. So if you follow this intersegmental artery more distally, it has different branches. The more important one would be the medial branch or the spinal branch. And you have other branches distally, the dorsal and the lateral branches. But let's focus on the radicular branch. So the radicular branch will give off other branches like the retrocorporeal artery, the prelaminar artery. And when it crosses the dura, it becomes a radiculomedullary. So the difference is radicular arteries are present at all levels, but radiculomedullary arteries are only present at certain levels. For example, in here, you can follow that this radicular artery crosses the dura, becomes the anterior radiculomedullary artery to anastomose with the anterior spinal artery. So that's what they're looking at. You have the spinal ganglion basically below, and here's the artery above. And then they divided this into 4 quadrants. See if I can maybe follow some of this. So you have here the lumbar vein. You have this is the inferior vena cava. This is the tributary to the inferior vena cava, the lumbar vein, and you have the intersegmental artery branching into different into the branches that I mentioned earlier. And the representative images are here. Again, the inferior vena cava, the tributary is the lumbar artery, and you have this intersegmental artery branching off. Eventually, you will have this radiculomedullary artery, and you have this nerve root. So they did a scatter plot. Again, this is for purposes of injection through the foramina. And if you can see here, you have the raw measurement and the normalized measurements. The overwhelming majority of the arterial location is in the anterior superior quadrant. There's a few in the posterior superior quadrant. There's 2. And very rarely there's one in the anterior inferior quadrant. And if you look at the scatter plot, there is nothing in here in terms of this anterior radiculomedullary or radicular artery location in the posterior inferior quadrant. So some guy has been making his rounds in the US trying to advocate for total abandonment of the subpedicular approach because the needle is somehow placed in between the posterior and anterior quadrant. So to abandon the this approach, the subpedicular approach, and totally just do a posterolateral approach targeting the posterior inferior quadrant to avoid injury to the radicular artery. So that's that has been he has been making his rounds all over the country. This is an example of a flat panel illustration. So you can see here this the artery, also a retrocorporeal artery, the radiculomedullary or radicular artery. You have the venous plexus by these arrowheads, and you have the facet of the higher or the upper vertebral body. You have the facet of the lower vertebral body. Again, they did measurements. And you can see here that this continued to become a radiculomedullary artery, anastomosing with the anterior spinal artery. On this axial, you can see the venous plexus, the epidural venous plexus. Here's your radiculomedullary artery, and here's your anterior spinal artery. So yeah, this is another example. You have the artery, you have the spur that narrowed the AP diameter of the neural foramen. And again, you can see the course of the radiculomedullary artery, and plus you saw the epidural anastomosing with the anterior spinal artery. So there lumbar foraminal volumetric dimensions. I can cite a few articles. We probably don't have a lot of time. I can send you these articles, but mainly, just briefly, they look at the volumetric analysis of lumbar foramina on MRI of 500 patients. And these are the results. You can see the progressive increase in neural foraminal volume as you go from L1 through L5 S1. This same article compared their results with CT-based study, volumetric measurement of the neural foramen. Although this had a very small sample size, 10 healthy patients compared to them. This is MRI-based 500 patients. Another CT-based a study on the dimensions of the neural foramen. Here, they concluded they found that the neural foraminal dimensions were 9.08 for sagittal AP, 8.93 for axial anteroposterior width, and then the height is 1746. So the the area is 134.78 square millimeters. So the conclusion was male subjects had larger neuroforaminal dimensions than females at multiple levels. Caucasians and Asian subjects had larger foraminal dimensions than African American subjects, which makes me think maybe that's good for me because of these results. But there were no association between foraminal and anthropometric factors. So this is CT-based, and so they made these measurements, which maybe I'm not sure about your experience. Maybe you can use it as a baseline or a reference. So this is the difference between the safe triangle. This is the safe triangle subpedicular approach. The hypotenuse of the triangle is the exiting nerve root, and the boundaries will be the end plate and the superior and inferior articular processes. Here you can see the radicular artery and the exiting nerve root as the hypotenuse of the triangle. You have the facet as the posterior boundary and the inferior boundary as the end plate on this safe triangle versus Kambin triangle approach. And this is needle placement, subpedicular, or the safe triangle approach traditionally versus posterolateral. And on the scatter plots that I've shown, the preferred target is the posterior inferior quadrant of the neural foramen to avoid injury to the nerve roots. So that was that. Here are just examples of needle placement in a subpedicular approach. They put the needle below the pedicle, and on the lateral view, the needle tip is abutting the periosteum of the vertebral end plate there. After injection, you can see epidural spread of the concoction plus the perineural spread without complication. Here you have the Kambin triangle approach, and you can see placement of the needle at the level of the disc. Here on AP, oblique AP, plus the needle placement posterior to the posterior line, posterior spinal line. And again, you can see spread of the concoction on the in the epidural space and the perineural space. So that was all I have for a 15-minute talk. It was fast, but I thought, I think the neural foraminal anatomy, the neurovascular structures, the scatter plot that they showed to me makes sense. Like I said, there was a guy making rounds to preaching to abandon the subpedicular approach with the proof of that scatter plot being no danger enemies in the posterior inferior quadrant.
Emilio, that was a great talk, and as the technique that we're gonna discuss is actually well connecting to your talk, because the first step of that technique is practically transforaminal injection. So we should know where to put the needle, and the papers and the diagrams that you showed, and also the MRIs and CT scans, was very insightful, and great talk indeed. So I have a few questions, if you allow me.
Yes, sir.
Actually, you showed a few slides. In your practice, what do you think is the significance of the so-called open facet sign? I think you showed a slide like that, significantly degenerated facets, and you see swelling inside the facet. That's one of the questions that I would like to ask you. And then the second question: how, let's say, grade 1 listhesis will change the anatomy?
Yes, sir. So let's start with your first question because it's easier. Grade 1 listhesis, in fact, depending on other factors, can widen the AP diameter of the neural foramen. But at the same time, if you have a pseudo bulge of subluxation, that will also play out in effacing the diameter of the inferior perineural fat. And if you have decreased the height of the disc, then that will also lower the vertical height of the disc. So I think, I have to see case by case. But in general, I mean, in theory, whenever there is listhesis of the superior vertebra, theoretically, it should widen the AP diameter. But there's also other factors. You will have a pseudobulge of subluxation, and that this material will efface the inferior and obviously also migrate superiorly. So that will play a role in the shape of that neural foramen.
Perfect. And if you see open facet sign like here, the one that you're showing, and let's say on a CT or on a CT scan, if you see a vacuum phenomenon, would you report that as unstable?
I don't have a lot of experience when it comes to the vacuum disc phenomenon, but I do think that that is a sign of it's telling me that it could be unstable because now you have the gas that is contained, and then they migrate into the spinal canal. And there will be some sort of, I'm thinking of the motion changes in that motion segment level. So maybe it gives you an idea that it may not be stable, just like when you have modic changes in the end plate. When it converts from fatty marrow to edema, then you are saying that there's some abnormal motion in that segment. So I'm not sure actually if, you can go, but I think it raises the concern about the stability. The open facet sign, of course, the facets, there's a lot of theory. I mean, I think that is a domain of the pain experts. But in terms of stability, I do think that it raises the question about the stability of that segment. In terms of, I think they talk about, in our literature, they talk about the facet as a pain generator, as a pain problem. Because of so many factors that I barely understand myself. But I say that, whenever all this abnormal motion happens in this sort of a little complex structure, then it raises the concern about the stability. And mainly for the patient is symptomatic generation of symptoms.
Great. Okay. Well, thank you so much, Vash. Do you have any comments or any questions? Anything you want to add or ask?
Yeah, actually, it's very interesting because I think having trained in the UK and moving to the States, there is a difference in practice. For the paying patient, if you have a vacuum disc, they would argue that they would do some kind of lift, either an X lift or an O lift or a T lift. One of the lifts, any of the preferred lifts can be done, and that's an indication for stabilizing, especially in the context of failed conservative therapies, etc. So they're much more aggressive than in Europe in terms of fixing and stabilizing the spine if there is an open facet sign and a vacuum disc phenomenon and the patient has back pain. So very aggressive with that.
Well, yes, we all know that there is a difference of the practice between US and Europe, and not sure how things are playing in Asia. Maybe Kim will tell us later. Right. Okay. So.
And let me. I just want to thank Emilio for this amazing talk. I think it was brilliant. I think it was really. Highlighted the anatomy and the close relationship with the structures, and made it very seamless for us spine surgeons to understand. And I'm very grateful for him having done this in the last moment. I suppose this is a good time to introduce our next speaker, Mr. Pev, who needs no introduction, I think.
Thank you so much.
Mr. Pev is again a very good friend, a mentor, and was a tour de force in spine surgery, and he has pioneered the use of Trans-Kambin approaches here in Belfast, and takes his teachings everywhere in the world. So he's going to do a brief talk next on how I do it. And floor is yours, Mr. Pev.
Thank you so much. Emilio, would you mind just unshare your presentation? So
Yes,
perfect.
sir.
So I can start with sharing my one. Okay, do you see the presentation?
Yes, sir.
Thank you so much. What I'm going to talk to you is I'm going to talk to you about this relatively new technique that is gaining speed in Europe and in the States. You can, I think because it's relatively new, still hasn't found definitive name. So you can see it in the literature as intralif, endolif, OLLIF, which is oblique lateral lumbar interbody fusion. You can find it as transforaminal Trans-Kambin lumbar interbody fusion. So there's many names. So I personally prefer Trans-Kambin fusion, transforaminal Trans-Kambin fusion, and I use that term. This is the trajectory that we are talking about. Sorry, as you can see, there is different approaches to the disc. So we are talking about this approach, Trans-Kambin fusion, which goes through the foramen and then through the Kambin's triangle, and then goes in the disc. So you can do different things with that disc. You can do discectomies, you can do fusions, you can do different procedures. So I have some problem with my slide switching, but I hope it's right. So let me present to you a case. Let me start with a case. This is I think this is one of the ideal cases for that technique. On the right-hand side, you can see a video intraoperatively, because this technique is completely percutaneous. So you see the X-ray imaging. So this was a 49-year-old, previously very active female running marathons. She presented to me with back pain and bilateral leg pain, and she was neurologically intact. As you can see on the MRI scan presented on the left upper corner, there is a grade 1 spondylolisthesis. There is open facet sign. You can see the facets at that level are very degenerated. So after discussion, we have decided that we're going to do the Trans-Kambin fusion. And you can see how the fusion is going. You put the screws with percutaneous technique, then you access the disc with a needle first. So the first step of that procedure is practically transforaminal injection. And then with sequential dilators, you access the disc while displacing the nerve root. The exiting nerve root is the main obstacle. Then you put a working cannula, and then through the working cannula, you have a lot of instruments that you can clear the disc, and then you can practically inject the spacer, the cage. I'm using an expandable cage that can go up to 16 millimeters on expansion. Length of the cage varies from 22 to 34 with 2 millimeter increments. So this is a cage that so bear in mind that my trajectory is oblique, is more oblique than the traditional TLIF, and because of that I am possible to use longer cages. You can see that this was one of my first cases that I have done. and I've done it with general anesthesia. The surgery duration was 70 minutes, which is good, pretty short duration for TILIF, and the hospital stay was 12 hours. The patient was discharged. A few things I would like to point after this. So I started this technique only after I was doing regularly minimal invasive TILIFs for the last years, and I have done good number of TILIFs. I also do a lot of injections in my practice. Last year probably I have done 500 to 600 spinal injections. I have previous cranial endoscopy experience. And lately, since 2018, I have spinal endoscopy, regularly performing transforaminal and interlaminar approaches. So far, with that new technique, with the new instrumentation that I have available, I have done about 60 cases. I wanted to show you this graph. This is like many of the minimal invasive approaches. This is a technique that is with so-called steep learning curve, because it is demanding for your understanding and for your skills. And there is a good publication on that regard from our friend Paulo Pereira and group. So they have established that for these new minimal invasive techniques, if you do 50 cases, you reach your 90% milestone and you're still novice in the area. And then every time you double your cases, you go to another level. So if you do 100 cases, you have a good understanding, but you still call yourself hobbyist. And then you can call yourself expert after you perform about 200 cases. So that is why the curve is steep, because every time you have to jump to another level, you have to double your cases. So this is the understanding. So this is like any technique has different problems. So this is, as I mentioned already, demanding, technically demanding procedure. The learning curve is steep and requires good number of cases. Screw precision is always a problem. If you have navigation, that is solving that problem to an extent. Your nerve is at risk, especially the exiting nerve route, and you may consider neuromonitoring to overcome that. In some cases and in some techniques, this is crucial, but in some other techniques that might be omitted. You have to work for the fusion rates because you don't have the traditional techniques to supplement and to improve your fusion rates. And because this is completely percutaneous technique, you have to think about the radiation exposure. You have to make sure that you're not getting so much, because you're going to be performing these surgeries for years, and then you're accumulating a lot of exposure, and like that, a lot of risk of possible complications. So I have included that slide just to show you how any technique that is that you perform, it's progressing with time. When you get better, you understand the technique better, you get faster and slicker. So this is an audit that I did on my minimal invasive percutaneous screw technique with simple X-ray, and you can see here that as the time was going and the cases, the number of the cases were going up, my timing was getting less, the X-ray timing was getting less, and you can see that at the end of this series of 800 minimal invasive screws, I have halved my timings. So this is typical for any technique, including the minimal invasive technique. So what is not possible in the beginning becomes possible later on. So the fusion rates are always a problem with these minimal invasive techniques, and a lot of people are talking about that. So on that left-hand side, I present to you basically this is a space for corpectomy. So I have done a corpectomy here, and then you can see the end plates, the way the end plates are prepared. This is the standard normally we have when we are preparing the end plates. Now on that right-hand side, you can see that this was one of my early minimal invasive TLIFs. I was preparing the disc for maybe 10-15 minutes, and then I decided to put an endoscope and to see how the disc is prepared. So you can see that the disc, the way the disc is prepared is quite different from the one on the left-hand side. So I think that, yes, there is techniques which, there is technical issues, and the fusion rates depend on the technique, but also sometimes it feels that we are blaming too much on the technique and too less on us. So if you are performing the technique properly, then it will work for you. So make sure that you are paying attention on how you prepare the end plates. This is my technique when I do minimal invasive TLIFs. I collect the bone dust when I am drilling, and then I put that inside the disc. Unfortunately, I don't have that option with this new technique, and then I will show you what else I do to supplement and to improve the fusion. Also, we mentioned that the nerve root is at risk. You know that when you're performing the minimal invasive TLIFs, the nerve root can be the exiting nerve root, and sometimes even the traversing nerve root, if you're too medial, is on your way. So there is different ways to protect that. I, for example, lately do partial facetectomies in order to stop the disc from being damaged. As you can see here, when you leave a partial overhang, this is protecting your nerve from being damaged. You can see that I'm checking with the hook here, and then you have this overhang that is preventing the nerve from being smashed on the pedicle, between the pedicle and your instruments. So unfortunately, we don't have this when we are performing that new technique. So we have to see what we are doing. And in this respect, Emilio's talk was very insightful to give us good overview of the foramen, the neuroforamen in a quite zoomed fashion. So this is the anatomy that is important for us to understand. We have to have a good understanding of the neuroforamen and the Kambin's triangle, and in particular the lower part of the Kambin's triangle. So we don't even have the whole Kambin's triangle. So and maybe this is one of the most important messages that I would like to pass to you. The lower end plate is your best friend when you're performing these techniques. And why is this? Because when you are docking your instruments close to the lower end plate, you are avoiding the exiting nerve root, and vice versa. If you are docking your instruments closer to the upper end plate, your exiting nerve root could be right in front of you, and then you can damage it. And this is because you have to enter that tiny space here when you are performing this technique. So you have to try to dock your needle at that point, which is the base of the superior articulating facet. Then you have to slide the needle right inside the foramen, and then you have to start dilating, and like that you will displace the exiting nerve root and create space for you to access the disc and perform the surgery. In that respect, and because this is completely minimal invasive, completely percutaneous technique, understanding of the X-ray anatomy is of crucial importance. You have to be sure to read the X-ray anatomy in the best possible way, and you have to be sure to acquire the X-rays in the best possible way. So you always rely on true AP and true lateral images. So if you are X-raying AP, always make sure that the object of interest is on a true AP image. And so, for example, if we are interested on the end plate, make sure that the end plate is aligned and it's not elliptical. Only then you're sure that you're on a true AP, and only then you're sure that the tip of the needle that you see on the image is actually exactly where you see it, but is not somewhere else. And the same thing is applicable on lateral X-rays. Make sure that you're true lateral. Again, if you see the end plate, if that end plate is in your interest area, if you are getting in that neuroforamen, make sure that this end plate is aligned, is not elliptical. Only then you will be having reliable X-rays, and they will be helping you to get reliable positioning of your instruments and not damaging structures. So when you start reading and learning about the transforaminal approach, or if you start going to different courses, you're going to see articles, you're going to listen on the courses, different recommendations on how much you have to be offset from the midline. So, for example, most of the offset that you read about L5S1 is 12-16 centimeters. At L4, L5, you have to go 11 to 14 centimeters laterally from the midline, 3, 4, 8, 10, etc., etc. So it was very difficult for me to get my head around it and to understand how, if somebody is 120 kilograms, if I operate somebody who is 120 kilos, and if I operate somebody that is 60 kilos, how these centimeters will be same. And of course, it's not going to be the same. So that's why I try to develop a way to avoid calculating centimeters, but get some sort of landmarks. So I came after I was reading literature and discussing with different people. I use now this 3-color zone. So if I on lateral, I built the so-called supraspinous line. I built that supraspinous line, and then the suprafacettal line. And then what's between the supraspinous and the suprafacettal line is my green zone. And then if on lateral, if my entry point is in that green zone, I usually say that's how this is projecting on the skin. So if you go in the red zone, that red is usually danger. If you go to the blue zone, it could be too steep. And this is how that is projecting on axial cut, for example. You can see that if you stay in that green zone, you're going to enter the neuroforamen safely. If you go to the red zone, you're too low and you may be entering the abdomen and you're damaging structures. And if you go to the blue zone, you might be too steep. Of course, if you have to access the disc, if you have to do, let's say, interbody fusion, you have to stay closer to the blue zone, or maybe just at the border between green and blue. And then if you would like to excise a disc that is paramedian, for example, you have to stay closer to the red zone, or maybe at the border with the red zone. So this is usually the planning that I do on the body on X-ray. You can see that this is my midline. Always take the midline, and then I put an X on exactly where the middle of the disc of interest is for me. I always make sure that when I put that X, I see the disc in an orthograde direction. And in order to assure that, on AP, I will see the lower end plate of that disc align, but not ellipse, as I mentioned already. And then I do same thing on lateral. And then and then I built a line, and then my entry point is usually somewhere in the middle between these two zones. If I would like to do a fusion surgery, if I would like to do interbody fusion. So of course, if you would like to be a little bit more steep, you can go a bit more medially. If you would like to go a little bit more towards inside the disc, you go more laterally. But if you do that kind of planning, you will definitely get inside the disc. And you don't forget that the skin is it also moves a bit. So if you do your stab incision at that point, you're usually safe. So biplanar awareness is very important when you do this type of surgery, because you have to advance your instruments practically blindly. You don't have anatomical landmarks and you have only x-rays. So you have to read the x-rays properly. And this is how you advance your needle, for example, or any other instrument. And this is your endpoint. This is the endpoint of the spinal needle that you're going to start your surgery with for any of the transforaminal approaches. And two important lines I want to stress to you. This is the posterior vertebral line, and it is good to see your instrument docking on the posterior vertebral line on lateral x-ray, true lateral x-ray. Don't forget, the end plate is always a line. And then you have to make sure that your instrument or needle or dilator is not surpassing. If you are on the posterior vertebral line in lateral position, in AP position, you should not be medial to the medial vertebral line. Medial pedicular line. This is the pedicle here. This is the pedicle. So this is the medial pedicular line. Make sure that the instrument on AP is not medial to the medial pedicular line, because otherwise you are inside the dura. And this is how you should imagine your instrument if you obey these two lines. Your instrument is right on the disc, but it's just laterally to the dura, so you're safe. So this is a good position in case you are performing, let's say, if you're planning to do a interbody fusion. So here on AP, you are just on the medial pedicular line, and here on lateral, you are surpassing, you're inside the disc. So you are safe. You have entered the disc laterally to the dura, so you can do your surgery safely without damaging important neural structures. This, however, is not a good combination. You can see here on lateral, your needle or your instrument is just docked on the posterior vertebral line. However, as I mentioned before, on AP, you are surpassing the medial pedicular line, and that means that you're inside the dura. And that is, just imagine if that's a needle and that you don't appreciate that position and you start dilating after the needle, you have to put your dilators, and then you have to put your working cannula. If you start doing that while you're intradural, you're gonna cause serious damage. That's obviously not going to be good for your patient. Another position that is not very good on AP, your instrument is just shy of the medial pedicular line. However, here you have surpassed significantly the posterior vertebral line. You're in the abdomen, so maybe here you are damaging abdominal structures if you continue to work in that position. So again, medial pedicular line and the posterior vertebral line. This is at what position you have to enter the disc. And if you make sure that you enter position in that position, you're safe and it'll be possible to safely do your surgery. After docking your instrument, you can then introduce the working cannula. And this is the position that you're chasing. The working cannula is going to follow the dilator or key wire inside the disc, and you can perform the surgery. So inadequate decompression is something else that we constantly hear about, this endoscopic and minimal invasive surgical approaches. This is, for example, on the left-hand side, the standard of the decompression that we can do if we do minimally invasive. TLIF. However, with the endolif or with the Trans-Kambin, we rely only on interbody indirect decompression. But I'm going to tell you that the power of the indirect decompression is underappreciated. And I think it's you can do a lot of cases and you can do a lot of patients only considering indirect decompression, because with indirect decompression you will increase the volume and the height of the foramen, and you will increase the volume of the area of the cross section of the thecal sac and the spinal canal. And also because of ligamentous you will be possible to reduce completely or to greater extent. This is a good example showing you exactly that. The ligamentous is converting the listhesis to reduced position, and also by increasing the height, you're increasing the volume of the foramen. And it's a simple mathematics. This is the so if you consider and if you imagine the neuroforamen as a cylinder, and this is the formula of calculating the volume of the cylinder, you can see that even a slight, like couple of millimeters really increase of the radius of this cylinder will give you significant increase of the volume of that cylinder. And this is the power of the indirect decompression. And in many cases, that will be enough. Fusion rates, as I showed you with my minimal invasive TLIFs, I'm collecting all the bone dust and I'm putting it back in the disc. Unfortunately, with that technique, we don't have that luxury. So I'm supplementing and trying to improve my fusions by inserting in the disc beta calcium, tricalcium phosphate mixed with blood from the vertebral body. There is good research to suggest that aspirating 5 mils from the vertebral body through the Jamshidi needle that later I'm going to use for the vertebra, for the cannulation of the pedicles. I aspirate 5 mils of blood, and it's there's a good research to suggest that in the first 5 mils you will have a lot of osteoblasts. Then you squirt them in the tricalcium phosphate. You mix it nicely. I usually squirt also 1 mil of Omnipaque, so I see where that substance is going when I'm injecting it lately. And that is showing you why. You can see this is one of the last cases I have done. I do normally pre-filling, and then I also do backfilling of the disc space. You can see here the immediate post-operative. There was no material in the foramen, but you can see here that some of the material came back. It is normal when the patient gets up. This is erect X-ray. Some of the material squirted back, but because the material is nicely mashed, and I think we are facing that situation. I have a little bit of a material between the exiting nerve root. So I think that that's why the patient is completely asymptomatic and she is not having any issues. But anyway, for future, I'll be a bit more careful how much I'm backfilling, because next time I might not get away. So cage size is also criticized with these minimal invasive techniques, because understandably we use smaller cage with that technique. As I mentioned to you, the cages, my cages that I use at the minute between 22 and 34 millimeters. Lately, 34 is becoming standard for me because of the oblique course. I'm possible to put 34 even for women and small patients. The width 8 and 10 millimeters. I started with 8 millimeters, but now I'm progressing to 10 millimeter width, which is a normal width of the cage, and expansion goes to 16 millimeters. In certain occasions, I might consider injecting 2 cages through one and the same neuroforamen. You can see this was a big girl. You can see the distance here. and she was osteoporotic. You can appreciate that from this X-ray. And I was concerned that one cage will not be holding enough, so I decided to put 2 cages through the same neuroforamen, and like that to assure that I have more space that is holding, and like that to hopefully avoid subsidence. So far, this is the case. A few words about how big are the cages. As you can see here, this is a regular situation in a TLIF scenario. You can see that usually the TLIF cages, they can be 10 to 12 millimeters, up to 30, 32. This is the area that you can cover, and obviously that is good enough, but it's not a massive area that is covered. With the PLIF, because you use 2 cages, you have a little bit better situation. With the Trans-Kambin, I think it's comparable to the PLIF because of the oblique course, you put large and long cage, 34 by 10, but also if you really need, in case the patient is osteoporotic, you can inject a second cage and you can supplement further, so you can get relatively good area. Future development, this is what I'm looking at the minute. There is certain companies that are developing half cannula that will allow me to put bigger instruments and protecting the aortic nerve roots, and also the cages that are expanding not only up down but in lateral direction. This for me, I believe that's going to be a game changer. Technique limitations for me for now: high-grade listhesis, severe deformity, severe stenosis, sagittal balance correction. I mentioned to you spinal injections. The procedure starts with spinal injection practically. Every transforaminal approach starts with transforaminal nerve root injection. So if you're doing injections, you're going to be possible to train your eye to read better the X-rays and trajectories. So maybe it's a good idea if you consider starting transforaminal work to start doing some injections. This will be the standard, roughly 4 or 5 centimeter offset. When how most of us do the transforaminal injections. In the beginning, I started doing with significant bigger offset and using a needle that is not 9 but 16 centimeters, and like that I was possible to train the new trajectory that I was planning to start. This was good for me. It was good for the patient, because with this trajectory, if you have a very narrow and stenotic foramen, it's very difficult to get in, while with this nearly 100% you will be possible to get into the neuroforamen. Other factors that you may consider: supporting team is important. The scrub team, your anesthetist, radiographer, and you can consider faculty surgeon in the beginning. This will be one of your first patients: young, fit, slim, L4, L5, grade 1 listhesis. Avoid significant degeneration and very tight foramen, and avoid anatomy variations. In particular, iliac crest could be on your way. Be prepared for complications. I had a few complications. I had this cannula that broke, and I was possible to fish it out with the expandable reamer that I have. I've locked 1 cage in the abdomen that is still there and is doing nothing, so I'm leaving it. Make sure that this is a new technique. You understand the new technique. You have a good team. Otherwise, it could be overwhelming for you and for your scrubs. And then you will have breach of the sterility. You can have infection. Make sure that you don't overtrust that this is a small stab incision, and you still close it properly. Otherwise, you will have gappings. A few words about the radiation exposure. All these techniques that we do it with X-ray. The X-rays are our eyes. We don't have the normal landmarks. So learn how to prevent yourself being irradiated excessively. So if you're not keeping your hands on the field, you're not gonna get direct radiation, so you're gonna get scattered. That's what you're getting from the X-ray when you're working with X-ray. You get scattered. So there is ways to minimize the scatter that you're getting. This was interesting slide for me. You can see here that the bigger the patient is, you're getting more scatter. See, the scatter is going exponentially. So if you're operating bigger patients with high BMI, you're going to get more radiation. So learn how to keep yourself safe from radiation, and you learn where to stand. You can see usually that's the normal position that we keep the X-ray. This is the detector, this is the tube, and usually the scatter is higher towards the side of the tube. And same thing here, you can see that's the top is the detector, the tube is at the bottom below the table, and you can see the scatter is most significant below the table. And it 30 centimeters only, if you step one step back, you reduce the scatter twice. If you do 2 steps, it becomes 4 times and more. So the distance is very important, and where you're standing when you're operating with X-ray is very important. So the scatter on the side of the tube is significantly higher, as you can see, comparing if you're standing on the side of the detector. So choose your side wisely. That's the same thing, choose your side wisely. And interesting research that comes from Korea. As you know, Koreans are big in minimal invasive and endoscopic techniques. So this is a paper that I quote quite a lot. You can see somebody is operating here, minimal invasive technique. This is the worst situation. Make sure that you never see your hands in the field. Number one, your hands are getting direct radiation. Number two, that means you're too close. So as an interesting research, there is 2 detectors. One detector is wrapped with a lead glove, and it's on the side of the patient. Detector B is not wrapped with a lead glove, and it's only 20 centimeters away from the surface. And interestingly, detector A that is wrapped with a lead glove is getting more radiation comparing to this that is only 20 centimeters away, and it's not protected with lead glove. So this is the importance of the distance when you're talking about the scatter. 20 centimeters, 30 centimeters, step one side, one step back, 2 steps back if you can, and then ask for X-ray. So protection is important. Make sure that you know the distance is the most important thing. It's more important than protective measures. If your X-ray technician is good, he will collimate for you, and that's going to reduce significantly the dose. If they're very good, they will do these markings on the X-ray and on the floor, and like that, they will not give you these parasite images searching for the best image. They will go to the best image straight away when they're changing AP and lateral. And this is very good idea, and that's going to reduce your X-rays significantly and your scatter significantly. Some people prefer to use 2 X-rays when they do these minimal invasive techniques, and like that they save time between changing AP and lateral. However, that leaves you less space to manipulate instruments. Also, the sterility could be a problem. You can just imagine that this surgeon has good sleeves here and everything is nicely draped. If you don't have that, you're going to have more infections, and you're going to have not so much space to work. And thank you. That was from me. Thank you so much for your attention and for being with us today. And I can see now that we have Kim. Unless there is any questions, we can continue with Kim. Any questions from the auditory? Anything you wanna mention? Great. Okay. If there is no comments and questions, it is my great pleasure to introduce Professor Harrison Kim from South Korea, who has extensive experience with endoscopic and minimal invasive approaches. And he has thousands of cases under his belt, and he's having courses all the time, and he's teaching all over the world. Proud owner of his own hospital at the minute in Gangnam, the famous the famous neighborhood in South Korea. And so, please, Kim, I can't wait to see what you're going to present.
Thank you, Dr. Nikolai. Okay, I will share my slide here. Okay, can you see my slide?
Yes, carry on, please. Thank you.
Okay, thank you so much. Dr. Nikolai P., thank you so much for your great talk. Your great talk is very, very useful. This time my talk is how I do it in endoscopic transforaminal mandibular fusion. I'm Hyun-Sung Harrison Game from Harrison Spin Arch Hospital, Cheongdam, South Korea. This is my curriculum writing disclosure. Yeah, we know that some endoscopic spine surgery in now developed so much, and then there have two evolutions that some first is that some we can possibly do the endoscopic decompression, and second evolution is that some we can possibly do the endoscopic lumbosity fusion. Because of that, so many degenerative diseases may be not only related to the disc pathology, but also in need some decompression, and sometimes in need some fusion surgery. And also, it is also not only developed by the importer, but also it developed with some collaboration of the biportal endoscopic spinal surgery. And also, if we met like this patient, there was a 60-year male patient with some severe disc collapse and some, you can see here the so severe spinal stenosis and some spondylolisthesis together. In that situation, maybe so many doctors will have some thinking how can solve this problem. Firstly, in either operation by directly or not, the operation maybe it some delay, and also it can possible by the endoscopically or some in either some open surgery for this patient. Also, these cases can possibly solve this problem by the posterior or some anterior. Because of that, like this very serious cases, before time, many doctors they try the anterior approach, but we hope to solve this problem as possible as minimally, uh, and also how much big size kg can possibly insert these cases. Before Nikolai people talking that it can possible indirect decompression with the high disk height restoration. Because of that, we also hope to insert more bigger and bigger kg. And also in either decompression or indirect decompression for this patient. It can possible indirect decompression. Also, uh, how much angle needed for this patient? It can possibly insert larger angle cages possible. This is some always debate for the degenerative disease the needed movement of fusion like this very serious cases. Firstly, technically, there have three kind of approach approach technique of the endoscopic lumen tower fusion. Nikolai people are talking that the Trans-Kambin approach. Yes, that's very great approach and that's very useful approach. But uh, some other approaches that some intraminal approach, but we know that so many cases currently we in need some the patient increase more and more that the patient who need some fusion surgery, not only single level but also multi level, but also very serious cases like before cases. But in the situation, maybe I think that maybe Canvas approach is very nice, but if we can manipulate more successfully and sufficiently with some more wide working space, will give a more good clinical result. Because of that, I choose this post-lateral transforaminal myotomy fusion technique. Like this approach, I use the yeah. Yes, because of that, in this technique, we use this foreskin incision that can possibly use the same skin incision of the percutaneous pedicle screw. Also, firstly, skin incision to the above level of the ipsilateral side of the pediculateral border, and insert the working channel to the medial border of the facet area. Then search this Kim's point. Here, this paper, I already introducing that some Kim's point and Wu's point. And the Kim's point meaning that some most higher part portion part point of the superior articular process of the lateral border of the facet area. It means that this area is a most superior part of the SAP, superior articular process. This naming the Kim's point. If we search this point, we can very easily cutting the SAP, IAP for performing the fastest sacrificing in posterolateral approach, like this way. I will show the operation like that. Firstly, expose this Kim's point, this above level, this below level. This is a tip of the superior process, and we resect the IF from the Kim's point to U's point. Then now remove the IAP by the one block. And also limbar of the SAP also same method from the lateral to medial above the pedicle area. Then directly we can expose post the foraminal space like this way. Then we drill chronic adhesive drilling also very important to releasing the very severe collapse disc space. After then, we clear the end plate and then insert the cage like this way. Sometimes 1 kg and sometimes 2 kg. Many cases of L455S, I perform the 2 kg insertion and finally checking the where position of the kg, then performing the percutaneous screw like this way. Then I already mentioned that the first step of this approach, we first searching the Kim's point. Kim's point meaning that the tip of the SAP from the lateral border of pedicle. Then you can see this image, this SAP and the tip of SAP. Then drill from here to medial U's point. This naming the we know that this area is isthmus. Then you can see here the search the lateral border of facet, then resect this area. Then you can see the river of the SAP very easily. And also IAP also same method above the pedicle area from lateral to medial cutting to like this way. You can see here. And also removal of the SAP also very easy. And also next step, we docking the working channel to the transforaminal area. And also here, very important procedure will be in the endoscopic lumbar interval fusion. Very important two procedure is that some releasing the chronic adhesive disc drilling is first, and second thing is that the end plate denudation. That means that the complete preservation of the end plate with the detachment of the end plate completely. Disc completely. Then you can see here again, expose the foraminal area, then performing the chronic adhesive disc drilling like this way from medial to lateral. If we possible more to lateral, then you can see it, the so severe collapse disc can possible to release by spontaneously. You can see here this case is also very severe collapse disc, but after chronic adhesive disc drilling, you can see we can insert like this very large cage insertion is possible. And also next step will, second very important step will be the end plate denudation. You can see the not injured to the end plate, only denudation of the end plate. That means the completely preserve the fusion bed. Because of that, this is my paper published in the Global Spine Journal. In this paper, with the completely preserved end plates and using the 3D printed cage, the fusion rate is so higher, and also additionally, fusion speed also very, very rapid. For example, this patient also taken complete fusion only 1 year. Usually, so many cases we can check the 6 months later, the fusion already success completely near completely. And also, in some of cases, before I mentioned that the chronic adhesive disc drilling will be very important. In some of cases, very severe collapsed cases, you need some entry point drilling, then drilling. You can see like this patient like this, expose the entry point first. Now we can see the entry point here. It already very severe collapse because of that opening. The this space is very, very difficult. But firstly, we expose this area, entry point area, and the plate, whatever body area. Then drill and drill this area. Drill again. Some pushy. Drill again. Some pushy. Now we can search the disk space, then drill of the entry point again. Sometimes push it to the disk space. Then, if it's possible, we preserve the some vertebral body. Then you can see now some opening the disk space. Then drill more lateral part again. Okay. Then now more wide of the disk space, and then drill again. Only disk space drilling, not injured to the vertebral body. And then finally we can see the more wide disk space, and then post-operatively you can see the some larger cage insertion is possible for this patient, severe collapsed patient. And also, some another important point is that these cases of so long time severe collapsed disc, the end plate that have a so uh, uh, bad tissue attached to there. Because of that, some clearing that area also very important. You can see here very chronic adhesive disc drilling already. Chronic adhesive disc already here located here, and after drilling, still here thick tissue attached to here, then clear to here, and clear to here again. Then okay, every tissue detached from here, then still thick tissue attached to here, detach and detach. And finally, we can see the very clear of the end plate with the complete preservation of to here. Then after that, we can insert a larger cage, and also we can take some good fusion rate for this patient. And also, in the endoscopic lumbar interval fusion, Trans-Kambin approach and also post-lateral approach, always all doctors some worry about it, how to insert the cage safely. But you can see here, this cage is Harrison cage glider developed by me. Yeah, it protects the traversing actin level together. First insert like this way, and then rotate like this way. Protect the traversing and actin level. You can see here. Push, push and insert through the obturator. Then uh, the checking, feeling the vertebral body and rotate the working channel like this way. Then insert the cage to the target point like this way. After to the cage to the target point, we can push the working channel, then the cage to the target point. Then we can see insert the cage like this way. Okay, I will show again. Firstly, incision of the skin from the above pedicular lateral border and insert the working channel to the medial border facet area. Then resect to the SAP, IAP. Then insert to the chronic adhesive disc drilling. After then, insert the working channel to discuss this area. After then, insert the kg and one more kg again to here. Like then, we can see like this figure. The post-operative, you can see the skin like this. In the scientifically, it already introducing that some disharrison cage glider that protect the nerve root. It already introduced this thing, and also the some resection method of the IAP and SAP. This already introducing in the paper. And also, it already mentioned that the effect of the chronic adhesive disc drilling and endoplate denudation will be very important point in the endoscopic lumbar interval fusion. It also already published in the paper. For example, like this very severe collapse, the segmental collapse cases after chronic adhesive disc drilling and endoplate denudation, you can correct this severe segmental collapse like this way. And also some like this case is also very severe disc collapse, and also with some opening vertebral body disc drilling and the endoplate drilling, then you can insert a larger cage like this way. And also in the cases of the, sorry, sorry. Sorry again. So like this cases of a severe collapse, the high-grade spondylolisthesis cases also can possible to reduce like this very successful disc restoration and spondylolisthesis restoration. Uh, I thinking that maybe complete restoration of the disc height is very, very important to improving the spondylolisthesis and improving the indirect compression and also improving the spinal alignment. Because of that, this chronic adhesive disc drilling is a very important skill. This is my paper and another Dr. Naoki's paper talking that with the after follow up the some CT image, we can see the trabecular bone remodeling after 3D printed KG. And in my paper talking that using the end-plate denudation and 3D printed KG insertion, we can see the very excellent fusion rate and fusion speed. You can see this patient, you can see this year, January, he performed endoscopic lumbar interval fusion. And 6 months, 8 months later, you can see the all fusion bed already completed only 8 months later, in spite of the osteoporosis. And also you can see this case is also very serious cases of the severe collapsed cases. And after endoscopic lumbar interval fusion, we insert the 3D printed KG. Then you can see that this image is taken 6 months later. This image also taken 6 months later. And also this image is taken 1 month later. The lumbar interval fusion already completed. And also, Nikolai talking that in the endoscopic lumbar interval fusion, there have indirect decompression is possible. This is my paper published in the Neurospine, talking that with this kind of restoration, so many cases, the indirect decompression is possible because of that. Like very serious stenosis cases, without serious stenosis cases, mostly they need some cage insertion is only is can successful operation is possible. Now we can try the more new trials for the degenerative spinal disease. We're using the endoscopic lumbar interval fusion like some without transfusion. We perform so many cases of the lumbar interval fusion, but in the cases, the transfusion rate is so low because of the we perform the endoscopic lumbar interval fusion. This patient also receive the 4-level lumbar interval fusion and also receive the transfusion maybe after post-op 1 day, one pint of transfusion only. And also we because of that we try to the no open surgery, no general anesthesia, no suture, no dressing, no transfusion, and no infection. And also, currently we try to the larger angled KG. We try 12 degree, 14 degree, 16 degree, 18 degree, and also KG. Nikolai talking that the expandable KG also can possible 16 degree. But in the static KG also we can insert can possible 16 degrees possible. For example, like this cases of L5S1, it need usually some large angle cage is needed for this patient for correction of the alignment and increasing the disc height. After endoscopic lumbar interval fusion, it is possible. This patient also inserted 15 height and the 16 degree angle 2 kg insertion performed for this patient. This is very important to correct the spinal alignment. It means that in the degenerative spinal deformity cases, this technique will be very important. For like these cases, they need some larger angle cage. L45, this patient also L5S need a large angle KG. And also this patient failed back surgery cases also to correct the spinal alignment, it need some larger angle KG that needed. Preoperative and postoperative you can see like this way, and this another cases also can see like this way. This another cases also can alignment corrected near completely after operation. And because of that, nowadays we can try to the degenerative deformity cases, especially scoliosis cases, degenerative scoliosis cases. Also, this paper already published in the World Neurosurgery, and this the cases published in the paper, and I show some another so many cases, and also In the endoscopic lumbar interval fusion, the structures not structures preserved near completely, not only some muscle, facet, and ligament, but also skin also very important to keep the structures. Because of that, in the after endoscopic lumbar interval fusion, so many cases of degenerative deformity cases that they have some they keep their concept of tensegrity. Tensegrity means that keep the structures tangent. That means that after with the keep the skin with the keep the all structures, then have a degenerative deformity cases after operation, they have a spontaneous restoration effect. I will show that. For example, like these cases with degenerative deformity cases, scoliosis and kyphosis, this patient need a received the 3-level fusion and pre-OP and post-OP, and 6 months later and 1 year later, the spinal alignment corrected spontaneously. Also, some another cases also, this cases also degenerative kyphosis cases. After operation, you can see like the 3-level fusion, and also you can see the spinal alignment from post-OP and 6 months later and 1 year later, uh, and 2 years later, the spinal alignment corrected by herself. This is very important concept of the future degenerative deformity surgery. This another case is also can see the receive the 4-level fusion due to the chronic discitis with the severe back pain, and after operation you can see the spinal alignment like this way. But 6 months later and 1 year later and 2 years later, the spinal alignment corrected by spontaneously, and because of that, the PJK usually not happen in the endoscopic lumbar interval fusion for degenerative deformity cases. Now I will show the some of cases. You can see like this case is a very, very severe collapsed L 5-6 spondylolisthesis cases. In this situation, usually we perform the anterior approach for corrected increasing disc height and correct the alignment. But in this case, it's received the endoscopic lumbar interval fusion by the posterior, and after operation, you can see the this kite restored sufficiently, and also spinal alignment corrected very, very well. And also some another cases, this patient have a L5S1 ischemic spondylolisthesis that need a large angle cage needed for this L5S1. We know that in L5S1 with some so many cases have some failed fusion due to that some substance and some loss of their spinal alignment. Because of that, we hope to the larger angle cage and wide space of the fusion bed. But because of that, so many doctors they try the anterior approach. But if we can possible to the posteriorly like this way, the patient will take a very excellent result without some another damage of the another structures, only posterior approach with some epidural anesthesia. And also, we already saw that this patient of the L5S1 failed back surgery cases because of that. This patient already received the interspinous device and L5S1 decompression. But in that situation, the patient also very difficult to insert, correct the spinal alignment and increasing the disc height and making the fusion bed is very, very difficult. But if we possible chronic adhesive disc drilling and the endoproliferative denudation, then making the large angle 2K insertion is possible, the patient can possibly take a excellent clinical result after operation. This 1 year later. And also this patient cases also we already saw that some failed back surgery and they need kyphosis and scoliosis correction. With the chronic adhesive disc drilling, it is possible by the only posterior approach with epidural anesthesia without general anesthesia like this way. And also, I will show some very difficult failed back surgery cases. This also failed back surgery cases before receiving the fusion surgery and fracture. After endoscopic lumbar interval fusion, you can see the spinal alignment corrected very, very well, and the patient also take a very excellent clinical result. And also, this case is also some another interesting cases of the degenerative deformity after with some failed back surgery. This patient received the L45 lumbar interval fusion, also degenerative scoliosis here. But if we can do the same manner, we can correct like this patient, very well correction of this patient's spinal alignment. That means that more good chance to the patient to return to more good life. This case is also very interesting cases already before received the interspinous device with the implants, and but the patient have some degenerative scoliosis above and above, and also stenosis above level and foraminal stenosis together. Because of that, this patient maybe receive the operation. Maybe this patient have a very big surgery from L45 foraminal decompression or fusion, or 3-4 decompression, 2-3-1-2 fusion. But if we doing the endoscopic lumbar interval fusion, we can do this patient only endoscopic foraminal decompression, endoscopic decompression, and fusion only to here, and then in spite of that, we correct the alignment very, very nicely. And this case is of several cases of degenerative deformity cases like this, like this. And also this another cases of degenerative deformity cases. I perform degenerative deformity cases with some segmental collapsed point to insert the cage. Because of that, like this left side, this two right side, then after then the alignment corrected very, very well. And also some other cases, you can see this case is very, very difficult cases of degenerative deformity cases also. Uh, you can see the post-operatively the spinal scoliosis, spinal kyphosis also corrected very, very well. Yeah. If you met like these cases of the severe degenerative deformity cases, what kind of surgery do for this patient? Maybe I think that maybe so many doctors will some forgive or some for this patient, because of this patient already received the deep uh, brain stimulation, you can see here. But also some doctors will try some multiple deformity open, but this is very dangerous because of this is patient already have some heart problem and also some very old age. But if we can do this patient by the endoscopically with not damage another structures, then we can see perform like this way. The patient will take a very, very good clinical result after operation. You can see here again, degenerative scoliosis and after operation. Okay, sorry. This patient also interesting cases of the failed back surgery cases before received the deformity surgery from another hospital, but still have some kyphosis and PJK problem here. But I removed all this implant on. Then I'm only performing this thoracic lumbar interval fusion, single level fusion performed to here, like this way. Remove this another all implant. At the initial, the patient near complete plegic, mild, mild motor. But after operation, I already mentioned that sufficient decompression also. Post-OP, the alignment is not corrected sufficiently, but because of the we perform the endoscopy loop by tower fusion, the patient still keep the concept of tensegrity. It means that the patient they have a chance of a spontaneous restoration of spinal alignment. And then you can see we try the skywalk walking stem. It developed by me in my clinic, like this way. Then you can see 1 week later, and 2 weeks later, and 3 weeks later. The patient walk is possible, and 4 weeks later, the patient spontaneous walk is possible. Then 6 months later, the patient walking by herself. Yeah. Firstly, I suggest that ask for this patient what kind of surgery will do that, what kind of this height, what kind of the angle, what kind of decompression. But I will show the result for this patient. Yes, we inserted a 2 kg large angled kg, and also we decompression only one side, not bilateral side. Then you can see indirect decompression also done. Also, uh, large angled cage also inserted here. But because of that, the spontaneous well restoration of the patient alignment, and I believe that the fusion also will take a excellent in the future. Thank you for your kind attention.
Thank you so much, Kim. It was great and very interesting presentation. And as usual, you are showing amazing results. I was so much interested to see your theory on tensegrity. So that is definitely something very interesting that we have to pay attention on. You mentioned that in your clinic, after you did these cases, no suture, no dressing, no pain. So how long your patients stay after the surgery?
Fortunately, in Korea, maybe the culture is completely different to Western part. The patient, so many patients, they hope to stay more and more because of that. The patient usually stay about 1 week or 10 days, but the patient can possibly to discharge 1 or 2 days later because of the after 1 day after operation, we remove the hemorrhage. Then the patient no needed some additional treatment, only antibiotics.
So after the surgery, you put hemovac, yeah?
Yeah, because of
Okay.
that, in Korea, we discussed so many times in the endoscopic decompression, maybe they need some insertion of a hemovac due to the some a collection of fluid also making the some irritation of the nerve and the post-operative irritation pain may be happening.
Okay.
Because of
Okay.
that, we insert the drain or 1 or 2 days.
Do you use, what do you think about liposomal bupivacaine do you use that in your practice for infiltration after surgery?
Yeah, that's also very good. And also we tried some of cases and so many patients, post-operative pain decreased so much. I love it. But the in Korea is currently it use it.
Do you use it in the disc or just in the paravertebral tissues?
Whatever tissue.
Not in the disc.
Maybe still not tried to there, but I tried to that.
Okay. Okay. Well, I don't know if there is any other comments, any other questions. Seems like there is nothing in the chat. Anything else is coming? Seems like nothing is coming. Well, thank you so much for sharing your time Sunday with us. What time is with you now? What time is with you? What time is it there? What is the time in Seoul?
11 p.m.
Okay, we better leave you sleep because you're going to be operating tomorrow probably.
Yeah, I have
Okay,
tomorrow. I have 5 operation.
excellent. Good luck with that. And thank you so much. And I'll see you in Dubai.
Okay, see you in Dubai.
Bye-bye.
Bye bye.
Thank you so much, everybody. And with this, I am closing this session today. Thank you so much for being with us in the day. So sorry, there is one question here from Fadi. Yes, Fadi, please give us the question. So let me see if I can unmute Fadi. Hello?
Yeah, thank you, Lai, for giving me the opportunity to give you my question. It's very nice presentation for you and Professor Kim. I want to have one question actually for Professor Kim. It's regarding the cage, what he is using. All of these cages are expendable cages or not? And what is, in your experience, if some dural injury happened in the endoscopically, how you would advise us to manage it? Of course, the surgery should be done perfectly that to avoid any injury. But if there is some adhesions, some scars, and you do the surgery and some dural tear happened, how would you like to manage it?
Firstly, I use the static cage. In Korea, the expandable cage is not useful due to some government insurance system, and also I use the expandable cage before. There have some problems that some have some uh, sometimes substance or sometimes some fracture. Because of that, I love the static cage. Most problem is that the larger cage insertion is not possible before in the open surgery, but in the endoscopic interval fusion, we already releasing the disc height sufficiently. The larger ingredient cage is possible because of that. Nowadays, I love the static cage. In Korea, 3D printed static cage use is very useful, and many doctors use that the 3D print cage. First question, and your second question is that some dural tear. Dural tear also in the endoscopic lumbar interval fusion and the endoscopic decompression is commonly happening. In my fortunately in the endoscopic lumbar interval fusion, my experience. I performed already 1,000 cases of endoscopic lumbar interval fusion. There have three cases of dural tear, and one case, but fortunately, all dural tear can easily managed by the taco steel attachment. I already published that paper in the World Neurosurgery. Very easy. Attach the taco steel to the dural tear area, the dural tear solved very easy way. And but if not solved that, maybe some cases, maybe some needed the open convert to the open surgery, but usually not happening. Usually managed by the takoshi attachment. And also your third question is that some related to the some revision adhesion tissue management and direction. They're also very easy way in the endoscope lumbar interval fusion. Because of that, view of the endoscope view is very clear. Because of that, some revision is very easy compared to the open surgery. If you search the correct anatomy that you can, for example, like some bone structure, first researching, then you can very safely insert to search the anatomy in spite of the revision cases. Okay, Dr. Fadi. Okay,
Seems like
and also okay,
it seems like he's
Doctor.
satisfied.
What?
I'm saying
Uh,
he doesn't say anything, so he's satisfied.
okay. Okay, you would like to question that how long does your surgery take? Yeah, That also very good. But before time also my one level fusion endoscope lumbar interval fusion surgery at the initial time maybe need 3 or 4 hours. But currently my one single level lumbar interval fusion without any additional management, only single level fusion usually need 1 hour 30 minutes. That is it means that after learn the it become a master some near similar to the open surgery. One level, single level lumbar interval fusion usually need 1 hour 30 minutes.
Great. So Fadi is texting. He says that he thanks you, and thank you so much for your time again, Kim. And I think we don't have any other questions, and I'm gonna close the session today. Thank you all for your participation, and special thanks to Kim and to Emilio for the great talks.
Thank you.